let me just go over just a couple of things first. The first is with what I'm hopeful that you will be able to do at the end of this, and that is to identify the role of the environment and early experiences on food choices, and then identify at least one strategy that you can recommend to improve eating for these patients and families, help the family survive pickiness. Hopefully you'll learn more than one strategy, but hopefully find at least one helpful. And then be able to identify some resources as well for yourself and the families. I do not have anything to disclose financially. And we'll start first with the role of the environment and learning early experiences on eating and food choices. So let's talk some about that. And just to give kind of everybody on the same footing, here's what it normally develops for feeding skills. Usually the child starts out with breast or bottle feeding. Then there's an introduction to the spoon to learn how to handle solid foods. It's very much a learning opportunity. Then the sipper cup is introduced, then more textured foods like crunchy meltables, soft or easily chewed foods are introduced. The child then gains some independence to be able to pick up the food or start using the utensils to deliver food and use a cup. And then regular table foods and an open cup is typically kind of that endpoint that kids can do. And so this is the typical course for most kids. We think that really in order to for kids to be able to learn these skills, that really you have that interaction between the child is ready. So there's a maturation of both their cognitive skills, their developmental skills, their neuromotor skills, and then they are provided opportunities that match those skills. So once that maturation occurs, then they are provided an opportunity, and that's how they learn to eat. So as an example is that often kids are ready to start doing some solid foods about 5 or 6 months of age. Part of that is because they are now sitting upright. They're able to hold their head up. They are able to sit in a high chair or booster seat and accept those items into their mouth. Now, maybe most of it's going to come out at first, but that's how that occurs. You may have some children who cannot hold their head up, or they cannot do some of those skills that are prerequisite skills, in which case we probably are not going to introduce these things to the child because they're not ready yet. So we may have to work on those skills first in order for them to be ready to be able to eat. But again, it's that maturation plus opportunities for these kids. So how does that then become a problem? Well, there's lots of things that interact with the child that affects their eating and their drinking skills. So kind of to look at those things, we have the child, there's the child in the middle. And there's multiple variables that affect the child's eating and drinking. And so we have biomedical, experience, social environment, and learning. And we'll go over some examples of those in just a moment. So all of them, they kind of affect each other, and they affect the child's eating and drinking. So let's talk first about maybe some of those biomedical factors that affect that child's eating that can affect, again, it's going to affect their eating, so it may affect whether they become picky at some point too. And so some kids, there is a genetic predisposition and that they, in their ability to perceive taste and sensitivity to particular tastes, we think are kind of hardwired in. There are some who have ability to taste things more than others in terms of, may have some heard of like those super tasters, or those that maybe they are more sensitive to certain tastes from the get-go. And you may know of adults, for example, that continue to be somewhat picky, and it may have to do with their sensitivity to certain tastes or textures that may have been hardwired in for those individuals. Parents can often report that from day one, this child rejected anything I tried. Again, is it something that is medical physical, or is it something that is, once they have that into their mouth, that there is that sensitivity at that moment in time? And excuse me for just a moment, I'm going to turn on my air conditioning in my office because it is extremely hot in here with the door shut. I apologize. So for kids too, when we talk about medical or physical, this is that biomedical. Children with physical disorders that prevent safe eating may need to work with specialists on their skills, such as their chewing skills, or they may need to have adjustments in what kinds of things are offered to them, maybe thickened liquids, maybe it needs to not be any liquids, maybe they can't eat at all and they need to wait for their development, or working with somebody on those skills. Often it's a speech language pathologist who may be doing the follow along to look at their swallowing or aspiration issues. So those certainly can affect whether a child is eating or drinking, or to what extent. Let's talk about a whole nother diagnostic category, that being autism. We also know that up to, so the literature is very varied in the numbers. And so in looking at kind of the range there, I'm suggesting that up to 89% of the children with autism spectrum disorder display strong preferences for food. And that can be by the type of food, the texture of food, the color of the food, or the packaging or brand of food. Often these kids with autism consume a much narrower range or quantity of food, and they have much elevated rates of disruptive behavior with foods that are presented to them that are not their preferred foods. And so often it seems that families will say, my child used to eat a variety of foods, and then suddenly they won't eat those anymore. And that's often that feature with kids with autism, where they used to eat some foods, but they don't anymore, or become extremely picky, more and more selective in what it is they're eating. Many kids with autism have sensory sensitivity, especially sensitive to taste or smell. And it may, some of those disruptive behaviors, some of that rejection of other things may also relate to those restricted interests and rigidity, perseveration. So they will only accept, they only play with certain things, they only play in a certain manner, they do certain things with their toys, and it can be the same kind of thing with food. I will only eat the Trix yogurt that is in this package, and when they have the Trix yogurt in the Star Wars package, it's not the same and I cannot eat it. That's the kind of selectivity that you may see through many different things, not just with eating and feeding with kids with autism. Experiences play a huge role in what kids eat and how they eat. So one of the things that we know is that there can be conditioned aversions to food and drink. And many times it's either an acute or a chronic medical or physical symptoms are associated with the taste of a food. So maybe any of you might have that same experience where you ate something one time and you got sick. And so what we all do is, oh, I got sick on that food, and so I don't want to eat that food anymore. Oh, it must have been food poisoning. Oh, it must have been this. And we relate it to what is most close in proximity to what has occurred. It may have nothing to do with that food item. It has to do with that GI illness or whatever that discomfort was, that maybe was a physical discomfort of some kind. And so then once that occurs, we become much more sensitive when we see the food, we smell that food, we think about that food. And we may even get nauseous, or we may even experience some of that discomfort again, or vomit, because it's such a strong relationship there. Now, this can occur, these conditioned aversions can occur with just one exposure and last a long time. There are some kids where they vomit and they don't go back to that item again. We have some kids who vomit with bottle feedings and they just never pick back up on bottle feedings again. Other times we may have somebody who vomits a lot, may have maybe colicky, may have reflux, and they continue to eat. And so it's not always clear what it is for one patient or one child where that really disturbs them, whereas for another one, it really doesn't disturb them at all. And so other medical conditions, so that reflux, that gastroesophageal reflux, eosinophilic esophagitis, many times if somebody has EOE, they can say, oh, food is getting stuck. I can't eat that because it's getting stuck. And so they stop eating certain foods because of that. Constipation can create discomfort, food allergies or intolerance, certainly diarrhea, and choking incidents. I can't tell you how many of those where this little girl who choked on spaghetti at grandma's house and then quit eating. This person's choked on a Smartie and actually went down hard rather than chewing it first, and now won't eat anything. So those kinds of things can occur, that they were doing okay, and then now they are averse to certain foods or all foods because of that, what has occurred. We also have kids who maybe they're perfectly fine with eating a variety of things, and they learn over time to become more picky, more selective in what it is that they eat. It may not be a particular incident. It could be that it's an accumulation. So I usually think about this as being kind of that feeding environment. What's happening at the time that kids are eating that affects whether they eat certain foods or not. And many times it relates to how the parents or caregivers of some kind are offering the food. So as an example, one is grazing. Okay. If the kitchen is open 24 hours a day and the child can eat whenever they want to, they may not try new foods. They may not eat other foods because, first of all, we know that hunger affects what and how much we eat. And if somebody is constantly eating those preferred foods, they're probably unlikely to try other foods because they're just not hungry enough to motivate them to eat those other ones. They eat what they enjoy because they can. And so it's also that, the kitchen's open all the time. I can eat what I want when I want it. For short order cooking, or an altered menu, many times families will adjust what's offered to the child because the child doesn't eat what's prepared. And many times these families panic. And so if the child isn't eating at supper, then they get panicked about the child not eating at supper, and maybe they can't go to bed hungry, so I'm going to fix something else for the child. I know that they like mac and cheese, so instead of spaghetti tonight, I'm going to fix mac and cheese. And so the child then learns, I don't have to eat what's being served. I can eat what I want. And so it's just as much the parent teaching the child they can do that, which then reinforces the parent for doing it. And they're more likely to continue to do short order cooking in those instances. Another one, maybe you can all have guessed that this was coming, is who's role modeling in the family too. So we hear this in clinic is, well, dad's a really picky eater too, or mom's a picky eater as well. Now, is that because of how they interacted with foods, something set down genetically, something it's hard to say, but we've had this as well where the parent really wants them to eat a variety of foods because they're concerned about their nutrition. And then we look to see that the parent or parents are not good role models. They eat on the run. They eat preferred foods only. They eat what they want when they want. And so again, role models will help determine what it is that the child is learning to eat. And we certainly have that social environment as a factor too. There can be many, cultural factors that play into what is offered to the child and when it's offered, how they prepare the food, or how the feeding environment, and even the foods that are offered. Parents' experiences with food, especially those who have had a very negative experience with food, again, can often convey that in some way to the child when the child is developing their eating and feeding patterns in relationship with food. And then what happens in daycare and school settings, whether it's positive or negative. Sometimes kids will come home and they have eaten anything that's offered in daycare, but they don't eat those same things at home. And so the question would be is, how is it being prepared? What kinds of things are happening that are different at home than in these other settings? So again, those social environments are often very important in determining the child's eating and drinking patterns. So again, just to review, we've got those different variables that can set this up for a child who is learning to eat and drink, or after they have established that, whether or not they stop eating certain foods or they gravitate towards others or have very strong preferences. So let's talk specifically about picky eating and what that is then, and how that might be occurring, and then what to do about it. So most of the time we think of, picky eating, what we hear from families is my child won't try anything new. My child hardly eats anything. My child eats the same things every day. And this occurs on a very broad spectrum. So it could be all of those. It could be one of those. It could be something even that's a little bit different as well. But usually what we think of for picky eating is that they're eating a limited amount or variety of food. They're not willing to try new foods and have those strong preferences. For kids with picky eating, they may or may not have growth issues. That will depend on whether the quantity plays into it. All right. So picky eating in general, it can be so very common in young kids that there's a term for it. It's called neophobia, and that's reluctance to eat new foods. So it's so common in many children that it's considered a normal phase of childhood. And again, it has its own term. So food neophobia is not an uncommon thing for all kids to experience, or many, many kids to experience. Usually picky eating peaks between 2 and 6 years of age and declines across childhood and adulthood, although we all know some older adolescents or adults who are extremely picky eaters as well. So this is just in general. In fact, if we look at one study that was done that included 4,000 children with that prevalence of picky eating, you can see kind of how that it isn't that, a fourth of them about at 18 months of age continues to 3 years of age. And you can see by 6 years of age, it has reduced. So, it is more prevalent in the earlier years and becomes not as much of a problem as they get older. It may relate, one of the reasons for that, it may relate to the fact that as kids become more independent in what they're doing and they start to figure out that they can get control of their environment through eating or not eating or what they eat, occurs, and as they get a little bit older, other factors play in, like they're going to a friend's house and that's all that's being offered. They go away to school and they're going to have to fix food on their own. So it's very possible that some of those other factors play in, and that's why picky eating becomes less prevalent in general. So that's kind of what I call kind of run-of-the-mill picky eating, where it's that, oh, they may not want to try new foods, they may have strong preferences, but it's not that uncommon. And certainly there's things that we can do, but there may not be as many interventions that are needed for some of this as for others. So because some kids can be even more picky than just standard picky, if there is extreme picky eating. And that's where the DSM-5 introduced the term avoidant restrictive food intake disorder, or ARFID. And that's a label for extreme picky eating. And in order to get that diagnosis, it's one or more of the following four. It's that there can be a substantial weight loss or failure to gain weight, the nutritional deficiency, dependence on a feeding tube or some kind of supplements like Pediatrics or other formulas, and there can be psychosocial interference. So one or more of those is occurring in order for the child to be diagnosed, or the individual, it can be an adult as well, but the individual is diagnosed with ARFID, or extreme picky eating. It is not due to food unavailability, and it's not, even though it is sometimes classified within an eating disorder, it really isn't a true eating disorder because there is no body image disturbance. So they aren't trying to, somebody with ARFID is not trying to lose weight, and that's their primary diagnosis is ARFID, and they don't have that body image disturbance. It's also not better explained by other conditions. Now, ARFID in and of itself does not describe specific behaviors that have to go into it, and there's quite a bit of leeway in how you would define, for example, what is psychosocial interference. And really, it's not well defined. So does it interfere with them, in terms of thinking and interacting, kind of is how I would look at it. So just so you know, so sometimes we think of, okay, well, how do you get a diagnosis of ARFID versus maybe feeding difficulties or sensory issues and that. So DSM is under the mental health diagnoses, and so typically somebody who can diagnose the psychiatric and mental illnesses might use this term. Feeding difficulties is that medical term. It's an ICD-10 term. And sensory issues are often those that are diagnosed within, like, occupational therapy, for example. And so sometimes which term is used may depend on who is doing the diagnosing and who is submitting the bills to insurance as to whether or not it's acceptable for that person to use one particular term versus another. Whereas we may all be treating the same thing. It's just a matter of which term might be best used. Let me go through some information on kind of some looking at ARFID and that picky eating or neophobia, where it's that more standard eating. So let's take a look at this. So for those first four on this table, over on the far right under ARFID, it's maybe, because it's one or more of those. So one could be yes and the others are no, or all of them are yes. Whereas when we think about our picky eaters that many of you may see coming to clinic, there usually is not any problem with gaining weight. These kids are gaining weight fine on the foods that they're eating. Maybe there's some nutritional deficiency if they're not getting all of their, they're not eating out of all of the food groups, but many are. There is no dependence on supplements or tube feeding. And if there's a psychosocial interference, it generally is because the parent or family is bothered by it. And it's usually not that the child is bothered at all by this. When we look further down on this table, these are often associated with ARFID or considerations within ARFID. So there may be some sensory properties and selectivity based on sensory properties with our typical picky eaters. We will often hear the child who looks at the food and goes, "Ew, that's gross." Is that a sensory sensitivity or just kind of, I'm being kind of, oppositional or stubborn about this? So they may have some sensory properties, sensory sensitivities there, maybe. And they may be true sensitivities. They have certain tastes or textures that they like and others that they don't, but usually they'll eat a bigger variety in other areas. Again, in ARFID, that may be one of those areas. In terms of limited interest in eating or poor appetite, absolutely not for typical picky eaters, but that may be an issue with kids with ARFID. That fear of an aversive consequence, not with those picky eaters, but the extreme picky eaters, that may be an issue. And that last one on there, often kids with ARFID have anxiety as well. And so let me talk a little bit about that too, so kind of thinking about, those kids with those sensory properties, we think of as kind of being those avoidant kids, where the sensory issues impact the food selection. That limited interest in eating and poor appetite, you think of as that kind of that restrictive aspect where there's just little to no interest in food or lack of appetite. And then that aversive, we can sometimes think of a kind of a ARFID, almost a category of aversive where it may be related to fear, fear-based reaction. So a fear of choking, a fear of nausea, a fear of vomiting, a fear of pain or swallowing. And especially, as I said, with that EOE, those kids can say, it's getting stuck. I can't, I'm afraid that I'm going to choke. So just as of interest then, there was a study that was conducted not long ago, and they looked at 83 patients admitted to a partial hospitalization program for kids with ARFID. And so when they looked at kind of what were these categories, or what was it that they were admitted, and what was kind of some of these descriptors. So for those patients, 5% of them were primarily selective. Okay. There's 20% were selective and had an appetite disturbance. 11% had a primary appetite disturbance, but look at that other number there on primary fear. Almost half of them had a fear. And so it's kind of divided between a choking fear or a vomiting fear. And I certainly have seen quite a few then that have that choking fear, because again, I choked on something, I'm afraid I'm going to choke again. And 2/3 of them with that fear noted some specific incident had happened, or that they had experienced or observed something. There was somehow they interacted that way and it established that fear. So for young kids too, that fear presentation can be severe and acute onset. And usually for these younger kids, there isn't other comorbidities other than anxiety. And the hypothesis in this study that seems intriguing and would kind of make sense is that maybe that kids with anxiety or tended to be anxious could be at a higher risk of developing these phobias and behavioral avoidance. So that maybe these kids who are more anxious to begin with, that the anxiety may not have developed because of their interaction with food, but maybe some of these kids are more anxious to begin with. They have an episode that then now they don't want to eat because maybe they have that enhanced susceptibility to fear conditioning or fear cues associated with those anxiety disorders. So it's not a definitive, but it certainly would make sense that, as you're looking at these kids and think, could they have some anxiety also? That may be an important thing for you to look at with these kids who present with these extreme picky eating. So let's talk more about interventions. So what might you recommend, and what might you not recommend? Because that certainly is an important thing as well. So for these kids, so I consider them, I've kind of come up with 5 facts for intervention. That's been by pulling things from various resources. One of those is food preferences are learned by tasting. Okay, if you don't contact the food, you don't know whether you're going to like it or not. Whether it's because of the texture, the taste, those kinds of things. Yeah, unless you experience it, you're really not going to know. The more children taste foods, the more they will like them. Okay, the more they experience it, the more they will like it, in the absence of some ongoing negative physical consequences. So again, it's the more we interact with those, the more we're willing to do it. Initial reactions don't count. So when the child looks at the food and says, yuck, and then it never appears again, sure, that might not ever be eaten then. So those initial reactions to it, think to yourself also about things that maybe you try now that maybe you didn't try as a child, or that you eat now, but it's been because you've come in contact with it multiple times. Cilantro is one of those foods that I wasn't too sure about that, and kind of not so much, but the more I have had things with cilantro in it, the more I enjoy it. So I usually think of 10 to 15 times before you can really think about a preference change that they can establish that. And tasting really involves actually consuming the food. So touching it up or smelling it is really not tasting. So actually consuming the food to determine, is it something that I like? Is it something that I really like? Or is it one of those foods in a category that I just can't get past it, and I will never get past it? And again, we can think of some of those in our lives that we feel that same way about. And practice makes perfect. So the more we do it, the more we're able to achieve those goals and be able to eat those foods. So in general, when we think about looking at things for changing that pickiness, we want to treat the medical or physical issues. So being sure that there isn't ongoing vomiting, ongoing constipation, seasonal allergies. If they constantly have crud in their nose or dripping down the back of their throat, it's not going to be a pleasant experience to eat. Do they have EOE? Do we need to treat that so that they can not feel like their throat is closing in or that they're choking on something? We want to make sure they're safe to eat. Are we sure that these kids who are turning their nose up or saying no to food, that they can eat those foods that are being offered? They can safely handle those. And sometimes, especially for those kids who have a true appetite disturbance, they might benefit from an appetite stimulant to be able to get them to start tasting foods or eating more foods. We might need to consider that. So what about those kids that won't try new foods? There's that classic pickiness. My child won't try new foods. So one of the first things we think of, and kind of going back to that whole issue of, we're more likely to eat if we're hungry. So think about it too. So think about you go into a restaurant and you are starving and they hand you the menu, and I bet most anything will taste really good. And it could be just bring me whatever it is that you can get out of the kitchen quickest because I'm starving. And so we're more likely to eat the hungrier we are. Whereas if you've been nibbling, let's say you've been eating appetizers and now it's time to eat. And now you look at the menu and you think, well, I'm not that hungry. And so you're more selective potentially in what it is you pick from that menu. Kids are like that also. So we want to enhance their appetite where we can, setting up a schedule for meals and snacks. Timing of drinks. If we're drinking all day long, it's going to curb our appetite. Folks who need to diet are often told, drink a big glass of water before it's time to eat because it'll curb your appetite. So kids are the same way. And we might want to just give a few sips before, but after food, and then no grazing on the drinks. And keep meals short, because if, again, parents get into that habit of, well, they have to eat, so let's keep them at the table, that doesn't do any good, because they may not be hungry by the time you're at the end of an hour, certainly. They're not going to get hungrier. And so we also don't want to make it negative, and we want to make sure they have time to get hungry again. Want to make sure that we can talk to families about being a good role model. And it may not be easy, but if they're wanting their child to eat broccoli and they themselves don't eat broccoli, there's kind of a mismatch there. And so we want them to be a good role model. We want them to be a good role model for eating at the table, for eating when it's a meal, and not, oh, I'll just eat a little bit more later. We want them to be a good role model for lots of things that way. And families can't give up. So they may try to offer something once. The child says, yuck, and then it doesn't come back again. So that's where we have to talk to the families about saying, you know what, even if your child doesn't eat it again right now, you need to offer it over and over again. Remember, we eat with our senses. We look at the appearance of the food, the taste of the food, the smell of the food, all of those things. And if it keeps occurring over and over again and becomes normal, that it shows up, we're more likely to try it at some point. And parents can't be too concerned about the amount that's eaten. If we're trying to get the kids to try new foods, it can't be that from the get-go, my child's going to eat a cup of broccoli. It may be they eat a tiny little bit off the end, so that we start small and increase expectations. The other thing to remember to focus families on is that they get panicked. The child hasn't eaten a whole lot that day. Maybe they ate maybe a little something at lunch, and they're not eating at the end of the day. And parents then panic, and then they start bringing out anything. They start doing that short order cooking, and they get into that habit. Whereas young children, we think of as they eat for the week. Okay, they're going to, some days are going to be better for calories than others. But that's why we don't worry about their weight gain every day. Think about a 3-year-old that you would weigh every day. They're going to fluctuate a lot. So we can't be too set on that my child didn't eat lunch, so therefore at supper, I better offer something that's preferred. They're going to eat over the week's time rather than within the day or day to day. And one other thing to think of is parents often get distressed about the child tantrums. The child throws things, the child screams, and it creates for such a stressful mealtime situation that sometimes we have to just focus on, you know what, just say no thanks. Just tell me no thanks. Let's focus on having the child communicate nicely that they don't want that. Parents can often have a little less stress at that meal and be willing to kind of persist the next day then. We can increase motivation to try foods with using rewards. Now, this is sometimes something that folks hear that is not a good thing. So let's go over kind of the myths of using rewards. Sometimes we're told never use rewards for eating. Rewards take away a child's inborn desire to eat, and rewards are bribery. Let's talk about the facts here. So rewards are used successfully to teach lots of skills and change behaviors. Think about all the rewards that are used for potty training, but that, using rewards doesn't prevent the child from using the toilet. And so it's the same kind of thing for eating. And research does show us that rewards can be beneficial as part of a treatment package to increase intake and liking of fruits and veggies. Again, we're trying to use it as part of all these other strategies that we put into place too. It's not just offering rewards, it's these other things as well, with the schedule and the role models and those as also. And bribery technically is inducement to do something that's illegal and unethical. And so really, we are not trying, eating I don't believe is anything illegal or unethical. And using those rewards does not, we're not trying to get the kids to do that. So we are not using it that way. So again, why might we use rewards? Remember, the goal is to get the child tasting new foods. So if we can find ways to get them to taste these new foods, eventually these rewards are not needed because liking takes over. And I can think of, I've done this for so long, that once if we start with some rewards with kids, I can't think of a single kid that didn't kind of wean themselves away from using rewards. They just started eating, and the families would forget to offer it, and the kids would eat, and it's not a big deal. So using them is usually very temporary. Let's talk about some of these kids that maybe have more restrictive eating and maybe more issues. So how do we help those kids with sensory issues and fear? Habituation. We get used to it by being repeatedly exposed to it. So this is where trying to get the kids to gradually be exposed to it. What are they willing to do? Are they willing to be close to it? Will they touch it? Will they just lick it? Will they take a small bite? Gradually expose these kids to what they're willing to do. Could be just one and done. We're just going to do one taste, just one. It shouldn't be, we're going to do a cup. Okay. So in order to address that sensory and the fear, just tiny bits, just a little. Giving choices among foods, what foods maybe that the child used to eat but doesn't anymore, maybe focus on those. What foods might the child be willing to do? Offering it as a choice. Which one should we taste? Which one should we try? And giving them some control. We may need to accommodate texture preferences. So some kids like cooked vegetables, some kids like crunchy vegetables. You know, does it matter if it's cooked or if it's raw? You know, that if we need to if they're willing to eat carrots, you know what? Let's do whichever texture that they might prefer. Another thing is that if they have super sensitivity in their mouth, they may not be good toothbrushers either. Some of these kids, if we work on getting other things into their mouth and we desensitize in the back there and on the tongue, and we do it with toothbrushing that doesn't relate to eating, some of these kids do better and then start to have less sensitivity and are able to start eating other foods. And again, building in rewards within this as well. This is hard work. You did a great job. Why don't you have some extra time tonight to read? Or why don't we do an extra game? Or why don't we do this because it was very hard work? And in many of these, we think of, we're collaborating with the child, especially when it comes to those fear issues. Again, that sensory issues. Just because the parent doesn't have those sensory issues or fear doesn't mean the child doesn't. And so we really need to take account how the child views this. And the older the kids are, the more it's going to be up to them to work with the parent and with us on trying some new things or being able to eat those foods that they used to be able to eat. Some additional interventions that we think about. So for those kids on the autism spectrum, many times ABA therapy can actually help with eating because they work on routines, they work on visuals and schedules. Kids learn first then. They're able to better sit at the table. I eat, or I try this, or I come in contact with it, then I'm done. And they learn that routine, and it can be used within the mealtime situation. These kids who experience anxiety, we do have to be very aware of that and what might need to occur, because we may need to treat that anxiety as a way to help them then with being able to approach food or being able to eat better or resume eating. We may need to treat it. It's possible with cognitive behavior therapy, mindfulness and relaxation, sometimes with some medication to be able to get them to even be able to sit there with some food, depending on what their experience has been. And so here's where we think about some significant cautions. is that we can make problems worse. So what we don't want to do with many of these kids who are extreme picky eaters is not to eliminate those preferred foods. So we think of, let's not say, well, then you're not going to get any of those foods, because it's not going to motivate them to eat more food and may turn them off more of eating, or to set those demands too high. You're going to sit here and have this entire meal. We're going to go to this restaurant no matter whether you like that smell or not. Again, if we press too much, we could lose them. So kind of that big picture to review is that we want to make sure we've addressed the medical and physical. Are there other interventions that are needed? We can use rewards. We might need to do that graduated exposure, but patience is what's really needed to be able to get these kids to eat new foods, or to resume eating, or to be able to have a much more pleasant experience with eating. So I'm just going to skip through a little bit of this. So here's some resources that are great resources for parents, because you'll have access to these slides. There are some, like the Bites has workshops also that you may be interested in attending. That last one there has things that may be helpful for parents to use. And I always think about a pediatric dietitian can be extremely helpful in addressing that nutritional status, to see, is this child a picky eater but not in extreme distress? What are those sources of nutrients? Maybe some protein ideas, ways to boost calories, and can make suggestions if vitamins or supplements are needed, what to do for those. I am also happy to see picky eaters, kids that are diagnosed with ARFID, for evaluation and treatment. If you have access to our consult, you can fill it out that way, or our schedulers, or fax me. That's just our pediatric psychology fax. The thing to think of, though, for these kids, these are the kinds of strategies that we will be working on. And the older the kids are, the more it's going to be up to them whether or not they're going to make progress. Younger kids, we can adjust a lot of things. It's those older kids that we really have to have that buy-in from them. Not that younger ones we don't want to offer choices or have them participate, but they aren't always rational in their thinking. Whereas those older kids can often talk about it more and can tell us what we might need to do. So with that, I'm going to open it up to questions to see if anybody has specific questions. I think Coffee had some that had been submitted. I am hopeful that I've addressed some of those pre-submitted questions, but maybe we can address any others too.
Great. Thank you for this wonderful information and all the resources you've provided. Yeah, we now have time to take your questions, so please type your question in the question box. I'll get us started with a question that was submitted during registration, and that is, what do you recommend for children struggling to eat after having COVID? So they may have had loss of taste.
Mm-hmm. And we have had a few of those kids that I've seen. So sometimes that resolves, often it resolves, and sometimes we just have to have that patience and continue to expose kids. Those kids who it doesn't seem to be resolving, or it may change their taste in some way, if there's an absence of taste for some kids, if we give more stronger flavors, if we give them the more savory things, or the highly sweet things, highly savory, that may help to be able to they can taste that better. We may, if it's really truly something that lasts, they may have to be taught to enjoy food, and it may be a longer struggle for that.
Okay, thank you. We had a question come in. What about kids that have had a G-tube and now have an overall aversion to eating by mouth?
Sure. So great question. And we work with those kids a lot. And so many times with those kids, so if they have a G-tube, sometimes they're being followed here, or they're followed by a GI doctor. We do have a multidisciplinary GI feeding service that includes a GI provider, a speech language pathologist, a dietitian, and me. And so those kids are seen, and we offer suggestions from all those aspects to be able to help wean them off of the tube feedings. Sometimes they need to have intensive therapy in order to learn to eat, learn what things, some of the skills, because maybe they're okay with eating some purees, but no other things, or they haven't learned to eat at all. And we do have access to that. We do have somebody who works on intensive feeding therapy for those kids. And you could send that send those referrals to us.
Okay,
Sometimes individuals in the community can assist with that as well, especially speech language pathologists. Sometimes the occupational therapists can work on it too.
great, thank you. There was a question on how to view the 1 bite rule. I think that was one of the resources that you listed.
Okay. So more clarification, it sounds like maybe on that 1 bite and done.
Yes.
Yeah. And so for some kids, so if you have them sitting for a long time, that can be very uncomfortable for them, stressful. They get more and more disruptive because I want to be done now. And so by saying, well, just 1 taste or 1 bite and done with that new food, with that food that you're wanting them to do, gives them that clear start and stop. It's not forever. It's not through the whole meal. It's not for an hour. It's just 1 lick, 1 taste, 1 eating, 1 bite, and then don't have to do it again today. And so then maybe the next day, again, we just keep practicing, and maybe just 1 bite every day until they get used to it and it goes easier.
Okay, thank you. A couple more questions. At what point do you recommend feeding therapy for sensory aversion?
Mhm. I think it's really individual. So if it's to the point that it's extremely disruptive to the family, to what the child is able to do, maybe need to work on that. It kind of depends, because for many of these kids, there's more than one issue, and so if they're growing and their nutrition is okay, that isn't something that's as big a deal to the family, because they have many other things that they want to address instead. I mean, at any point, it can be addressed.
Okay, thank you. Would you recommend taking your child to the grocery store and allowing them to choose 1 fruit or veggie from the freezer section, or if they're old enough, taking part in the preparing of foods?
Absolutely. That's one of those where that's that child collaboration, offering choices. What color things, what looks good, what smells good to you may be very different to your child. And so involving them in that. And again, making them come in contact with the food in some way, even if it is in that preparation. We've gotten kids to start doing things like they started eating a pepper because it really smelled good. They were helping with that. Maybe not with a knife exactly, but they were helping in that preparation, and it smelled good. And one day they wanted to take a bite. And so after that, it's now included in their diet.
Okay, great. Thank you. What about children that were failure to thrive as infants, um, that are now struggling at age 4 with weight gain, but every doctor says it's just their age?
Hmm. So some of those kids, I mean, the biggest question with those is, are they truly gaining weight, that they're petite and they're growing, or are they truly continuing to fail to thrive? Because if they still are failing to thrive, then you may be dealing with 2 things. You're dealing with normal picky eating at that age, but it is affecting that child's growth and development. And so there really does need to be an intervention in that case. And so that's where, that our multidisciplinary clinic or specialists who can look at, is that child growing? What's their nutrition? How can we boost up those calories? What can we do to help on all of those aspects?
Okay, maybe we'll try to squeeze in one more. If they're 8 years old and get such anxiety when asked to try foods that they shut down and will end up crying, Should they see a good therapist, an occupational therapist, or see a psychiatrist?
That's a great question. And it may be a combination of those because I think the big thing would be maybe the psychiatrist, it could be a psychologist who can evaluate to see, is there a bigger picture there than just related to food? Is there an anxiety disorder that needs to be treated? Is there something that needs to be treated? Is this ARFID? And then how can they start interacting with food or be able to do that? So that they can eat okay, or they can eat things that they're wanting to eat or seem to important in their diet. And so they may need somebody who can help them with that. They may need somebody who can help them with relaxation strategies so that when they do have food in front of them, they can calm down, they can be able to interact with that food without getting so distressed that they're shutting down.
Okay. There's one more I think that might be of interest to folks. What about kids with diet preferences like vegetarianism? Is that considered picky? And then what age do diet preferences get set?
That's a good question. And I think in terms of, so the younger the child, often it's the family that there's that social environment that helps to determine about whether it's a vegetarian diet or what kind of vegetarian diet. And those can be very healthy if the child is getting enough nutrients, proteins from their sources. And so that's where a dietitian would probably be a really good person to seek advice from to be able to determine, is this a good diet for the child? Because you know what, if they don't eat meat, it's okay, they don't have to eat meat. If they don't eat eggs or they don't eat certain things, but can they get their sources of protein in other ways, in which case it may not be, it's perfectly fine for the child.
All right, terrific. Well, we're at 1 o'clock, so I'll close out the session today. I'll cover a couple housekeeping items and then um, send you guys all on your way. This course was certified for AMA PRA Category 1 credit. Attendees are eligible to claim continuing education credit by completing the evaluation and attestation form and downloading your certificate. I've included a handout of the step-by-step instructions. I'll also send this in the follow-up email. If you do have any questions, don't hesitate to email me. My email address is kafi, Kafi-Dixon, Dixon at uiowa.edu. I just want to again thank Dr. Cooper Brown for presenting today and sharing this wonderful information. And I'd like to thank you all for attending. Have a great afternoon, everyone.